Good afternoon. Today I would like to speak about the clinical evidences of oncothermia and showing the trend to the immuno-oncology of this method. The outline is simple. I would like to show the pitfalls, the rationale, and the clinical evidences. This is the main point, and then how to go further. So it's always a very important question that whom is recommended the modulated electrohyperthermia. The first group is that one when the patient cannot receive the other conventional therapies because of the comorbidities which she or he has, or no effective conventional procedure for the given tumor. The conventional curative processes can be fallen and only palliative setting could be applied. Patients with relapsed locally far advanced tumors, that is one of such kind of patients. Conventional therapy cannot be continued because of organ failure or low blood count. It's other kind of patients, and patients showing intense progression despite of the treatments is a third one. So again, we recommend modulated electrohyperthermia for this. And also we recommend when intense metastatic activity is shown and it's maybe a terminal case which has to be treated. The other question that why modulated electrohyperthermia has many single-arm studies. It's again very important, many times asked question, and the main answer that the conditions do not allow formation of appropriate cohort. The patients, all patients are different, and then we are not able to create a homogeneous cohort with similar patients because many pretreatments, many differences in the adverse effect and so on. And the other one, the placebo, is ethically impossible. So again, we have no possibility for the second arm. So mostly we are doing observational studies, and two main categories of the observation studies are made. The single-arm prospective trial. The protocol is not so rigid. No average patient exists, as I told, and possible solutions having a historical arm from the same hospital or propensity score, mining in the large databases, find comparable cases. The other category is the observation retrospective clinical trial or case reports. It's even weaker than the normal single arm in evidence meaning. The challenge is weakly comparable registered parameters. That's the problem. And possible solution, give therapy and register all patients who need it. It's called intent to treat process. In this case, the inclusion and exclusion criteria are more flexible than usual, so it's really all patients can be treated there, except who is contraindicated by the method itself. The strength of evidence may be increased by estimate survival in the mathematical distribution calculation, which I have published in 3 papers, or repeat the trial, which is very, very effective. Repeat the trial from different research places, different times, and then compare it, and maybe that we can reach the pool in the significant level. So let me see the clinical evidences. In 4 different categories I would like: safety, efficacy, quality of life, and economy. Safety. It was done in Regensburg University in Germany a long time ago and published in 2 times in Journal of Neuro-Oncology. The modulated electrohyperthermia was applied complementary to standard ECNO chemotherapy for advanced glioblastoma multiforme patients. Dose escalation was applied 2 times, 3 times, 4 times, 5 times, treated patients on brain, so very sensitive organ, like an intensive dose escalation. This is the result. These are the groups 1, 2, 3, 4, and these are the patients there, and these are the adverse effect which was measured. The grades are here, the numbers. You can see that the numbers of the grades on different patients are are different, so there's some different, but no any specialty in the fourth group, so the highest dose group. Even you see that the highest dose group has less adverse effect than the lower dose groups, so it means that no extra adverse effect was observable. It's very important because if such a sensitive organ has such a result, then we are expecting that other organs also safe. Efficacy, this is the most important point, and I show for you a single, very rare phase 3 randomized cervix trial, 210 patients, 2 years survival significant between the radiochemotherapy plus plus modulated hyperthermia, so without and with, and the median is about 18 months of survival, and in 3 years overall survival, which is also significant, it's almost doubling. So it's a very good overall survival results, and here's a disease-free survival, again significant in 2 years and significant in 3 years as well. So disease-free survival also better applying modulated electrohyperthermia to the standard therapies. Let me see the glioblastoma multiforme modulated electrohyperthermia in single-arm studies, because it has no double-arm studies due to the reasons which I have mentioned. So this is a 29 patients was measured in Hungary in a clinic, and this one is 35 from Canada, 126 from Germany, 24 from Italy, 92 from Germany again, and 19 from Germany. So 3 from Germany and the others. You can see that these are not significantly different, and you can make a pool which is 325 cases altogether, which very much differs from the historical control from the NCA database, and then the medians are about 3 times higher than the control. So it's really significant in this meaning. We can compare the glioblastoma multiforme with the Temodal treatment, which is very important because the Temodal is presently the best chemotherapy which can be applied. This is the well-known Temodal treatment. You see that radiotherapy plus Temodal or radiotherapy alone less than the modulated electrohyperthermia. So it means that the median is significantly higher than the Temodal applications or radiotherapy alone. This one again very important because the invasive hyperthermia can be compared to oncothermia, which is non-invasive, and this is the invasive hyperthermia with brachytherapy, also invasive, so they use needles into the tumor, and then 39 and 40 patients were involved, and this one is all pool, and you can see that about the same the median than with the invasive one, but this is non-invasive treatment, so it means that very convincing that such a non-invasive simple method like oncothermia can compete with the invasive brachytherapy plus invasive hyperthermia. This one is an emerging therapy for tumor treating field for glioblastoma. Patient has a head which has a lot of electrodes and a large battery, and they must wear it every day at least 18 hours, and for months, mostly maybe that half year or even more. It's not so good for the patient because when he or she sleeps, also has to be the head on. These are the results. This is a TTF plus Temodal, and this is the Temodal alone, so it means that it's much better. The tumor treating field are much better than Temodal alone. And this is our pool, and you can see that our pool is about the same like the Temodal plus TTF. So it means that we are at least the same like the TTF, but TTF is first line therapy. We are not first line. We have much higher lines, and the method, Oncothermia method, is cheaper, easier, and not loads so much the patient. So these are the medians. Advanced inoperable pancreas, which is again very important disease. Here's a SEER data from the United States, and this one was measured a historical control for 34 patients from Hungary, which is about the same like the United States. This one is from Canada, 25 patients. This one from Romania, 17 patients. You see, these are the differences are really large. Romania is not so well performing like the Canada, but the difference is not significant. So they are about the same median. This one is the Hungarian investigation for 26 patients. This one is from Germany, 34. This one is from Hungary again, 73. And this one is from Germany again, 42. So it's the distribution is not significantly differs, but differs very much. And it's mainly because the inoperable pancreas has many different possibility for metastasis, which in the glioblastoma was not the case. So it means that the patients are very different, and this difference can be seen here. But despite of that one, the pool and the pool of the control group are different, about 2 times higher the modulated hyperthermia than the control has. So this one is again the same, which I would like to show for you that we have newer results, and maybe that Dr. Andreas Szasz will report about it. It's 78 patients were published in last year, and this one is the Italian one, 106 patients, and it's also very good. It's much better, but it's not inoperable. It contains the operable and inoperable patients as well. So you can see that the development of the technology by the time, which is not so old like the other, that's really remarkable. Oncothermia metastatic non-small cell lung cancer. It's measured by many institutes. This was by Professor Lee from Yonsei University, and this one is from Hungary, 197 patients. This one is from Hungary again, 61 patients. This one is from Canada, 46 patients, and this one is from China, 49 patients. So again, we have no significant differences, but large differences anyway, because of metastatic non-small cell lung cancer, again, not so unified, so a lot of different metastases could be. This is a pool, 360 patients, and this one is the reference arm, so this is the difference is really significant, about double the median. Here is a comparison of this one with the different large databases. This is modulated hyperthermia pool. This is the SEER database, the Eurocare database, the East European database, and, which is very important, the best radiotherapy plus chemotherapy, even the best radio and chemotherapy for non-small lung cancer, less effective than modulated hyperthermia. This one is a comparison of non-small cell lung cancer with the small cell lung cancer. Two studies are compared. This one is from China, from Ganju Clifford Hospital, and you see that the reference arm and the active arm are different, and the median also differs not so highly but significantly. And this one is the small cell lung cancer. Professor Lee did it from Gangnam Servants Hospital, Yonsei University, and you see that the small cell lung cancer has less survival than the non-small lung cancer, which we were expecting, and the reference arm of the small cell lung cancer corresponds with the reference arm of NCI database. Colorectal cancer with liver metastasis, it's again compared to the US database. This one is a control for the control arm from the historical control from Hungary, which is a little bit worse than the United States database. And this one is from Germany, 30 patients with chemotherapy. This was the survival, and this one is without chemotherapy, 50 patients, the same researcher, very early results. But these early results are well corresponding with the new results from Italy. So you see that this one is from Italy. It's a little bit worse at the end, but they are really the same. This one is from Hungary, which was measured together with the control arm, 218 patients, and really better survival than these elder studies. And this one is from Canada, which 80 patients, again better than was. I must mention it that somehow this is the time evolving, which shows that the method is better and better, except this 2 years ago measured experiment, which is the same like very old clinical trials, and this is probably because it was applied different very heavy chemos, despite of that one, that alone the chemos were not effective. The next is the quality of life, which we can measure. The quality of life in the non-small cell lung cancer was measured with intravenous vitamin C application, and then the quality of life in function subscale. The physical was much better, so significantly better. All the others are also better, but not significant 4 weeks later than the treatment was done. And this one is the symptom subscale, much more significant changes, but everything which is not significant also shows the same, that the modulated electrical hyperthermia has good feasibility to apply, because 4 weeks later suppresses all the adverse effects in symptom subscale. This one is a phase 2 randomized trial. Also vitamin C was applied, and you can see that every points in conditional changes and physiometric changes, every points are better. So the significant elevation by modulated electrical hyperthermia in conditions, and significant suppression by modulated electrical hyperthermia by the adverse effects, by the quality problems. This one is the traditional Chinese medicine plus minus modulated electrical hyperthermia. Where modulated electrical hyperthermia is applied, then always we have better results. The overall response rate is much larger, the quality of life much larger, and no change, and worse quality of life less than in the control group. The pain relief is very interesting one for lung cancer. It's a case control study, so propensity score comparison, and you can see that the change to control, at first the pain intensity is lower after the treatment, but later it's higher. About 2 months it's growing, and then about 4 months it goes down to the no change, and then about half year it's 30% or 40% better, the pain relief, which is interesting that the effective energetic score, which was 0 in the baseline, very high 2 months later compared to the control. So it means that it's almost doubled, 100% or more than 100% change, and then it goes back and almost 100% half year later when this disappeared. So it means that the 100% disappeared compared to the control. This one is the uterus cervix phase 3 randomized study measurement, Dr. Mina and colleagues, and you see that 6 weeks or 3 months shows significant changes favoring oncothermia. This one also, the function measurement, the same. Everything is higher in the ratio between modulated hyperthermia and control, except the social, which is less, and which is very interesting that more than 4 different categories, including the pain reduction and almost 11 the vomiting problem, so suppressing the vomiting and nausea. The next is the economy, which is very important. Again, Dr. Mina has measured it in South Africa, which is important that the modulated hyperthermia cost and the chemotherapy cost in government are different, and the government modulated hyperthermia cheaper than the chemotherapy, and the same in private, but the private generally more expensive than the government. And here is the chemotherapy compared to the ratio to the modulated hyperthermia, and you can see that the chemotherapy always larger cost, about 9% or 6% in private. So it means that modulated hyperthermia more cheap than the conventional therapy. This is a glioblastoma multiform comparison when Temodal and modulated hyperthermia applied, and the cost of the survival years, and here is the cost for Temodal alone. The same results have much different cost for the treatment, keeping the patient in a good level in the follow-up. This one is the lung cancer, the same modulated hyperthermia cost in dollars, radiotherapy and chemotherapy. The difference is really huge. You see that it's 4 times almost the chemotherapy cost. It's 40 times chemotherapy cost than modulated hyperthermia itself. How to go further? So the further things is the distant response, immunogenic action. So for example, here is a case with breast cancer. It's a horrible large tumor, and it's treated with radiotherapy, but it became smaller, but started 2 metastatic spots, and then was applied modulated hyperthermia. Metastasis disappeared at the end. So it means that despite of that one, that only the breast was treated, the far distance metastasis disappeared. The same in the breast cancer by combined with ketogenic diet. The breast was treated and many metastases disappeared after the therapy. So it's really, again, shows the abscopal effect. Ovarian cancer with liver and spleen metastases also shows from Italy that the metastases are treated only the liver, and then everything is disappeared far away. Metastatic esophageal cancer was measured in Taiwan. You see that the esophagus was treated, and then the different metastases disappeared. But after the follow-up, about a year later, it started again. So probably next treatment is necessary. Metastatic urothelial carcinoma with abscopal effect, also the liver metastasis, this was treated, and then this is before, and this one is after the therapy. So the urothelial carcinoma and the liver metastasis disappeared 6 times. Oncotermia was applied together with radiotherapy. This one is the phase 3 trial abscopal effect from randomized study. These are the metastases in different groups, the modular hyperthermia HIV positive, modular hyperthermia HIV negative, and the same in control. You can see that a lot of metastases inside in percentages. And then here's the complete metabolic response measured by positive emission tomography. So it's not only the shrinking or disappearing the cervix tumor, but complete metabolic response everywhere in the tumor and extrapelvic nodes, and together everything is significant. Also significant, the all disease result measured by PET, the radiotherapy plus cisplatin plus modular hyperthermia, 24%, and the radiotherapy plus cisplatin is only 5.6. It means that even that one, that radiotherapy plus cisplatin is a systemic treatment, they have much less systemic response than when it applied a boosting by modular hyperthermia. And this one is the HIV, the same is the HIV groups, plus means HIV, the modular hyperthermia plus HIV and minus HIV patients. You can see that in both categories, Oncothermia has better results in the complete metabolic response. So this was this was my talk. Thank you very much for your attention. And if you have any questions, please contact me. Thank you.